So I was happy to see Mohita's presentation, and I've realized that all these press biopic treatments are quite dependent on pupil size. And I'm going to add more to it. So the treatment from Schwind is called Presbymax, and we'll just go a little bit into detail as to how it actually works. So here, of course, it's the same thing. Basically, what we do is three options. Here we are trying to treat. So from 2012, we are having this, and this is then going on till 2016. So there has been Presbymax, and this is dependent. This is of course on the Schwinn platform. It is a biaspheric multifocal corneal treatment. So we are creating biaspheric zones on the surface of the cornea. And first we had micromonovision, then it became hybrid, and today what we have is monocular. So what is the difference between each is what I will show, and how do we apply this to our science. So bottom line here is whether we use any of the systems available in the market today, we have to increase our depth of focus. So when we have a distant dominant eye and a non-dominant eye, this information is very crucial. And if you want to do micro monovision, in the distant dominant eye, we are creating only a 0.9 diopters of depth of focus, while we are creating a 0.9 or a minus 1.8 in the non-dominant eye. In a hybrid pattern of treatment, we are creating even lesser depth of focus in the distant dominant eye. And in monocular, it's just like the Zeiss platform, where one treatment for distant dominant is absolutely no depth of focus, but a minus 1.8 in the non-dominant eye. So we have three options on the Schwinn platform, which is with the Amaris laser, which is micro monovision, hybrid, or monocular. So all of this is applicable. So this is the depth of difference that we will get in Presbymax. In micro monovision, you can see that the dominant eye, we have more depth of vision, and the non-dominant eye is about minus 1.5. Presbymax hybrid, the dominant eye, as you can see in this chart in the middle row, it reduces, and Presbymax monocular is distant dominant works entirely for distance, and the non-dominant eye work entirely for near. So it's like a monovision or a monocular vision. The most important thing here, as rightly mentioned even by Mohita, is that you need positive thinking patients. Patients who will be more satisfied in my practice have seen that hyperopes are happy with this kind of treatment, and high astigmatics. Low myopes and myopes in my this thing are not at all happy with Presbymax, because they tend to compare with the normal vision that they have. And again, I say that we are creating a biaspheric surface, which is on the surface of the cornea. Very important that these patients do have a trial with contact lenses which are multifocal. So in multifocal contact, if you are doing micromonovision, we target for a -1 residual myopia in the non-dominant eye, which is your near eye, and a target distance for 0 for distance, which is in your dominant eye. So you have a medium at power in both distances for distance and near. So this is micromonovision. In hybrid, of course, it's little lower than what we did in micromonovision. And monocular is entirely like a dominant and a non-dominant. The dominant eye works for distance and the non-dominant eye works for near. All of this, of course, we are going to create asphericity on the surface of the cornea, which gives additional depth. But the summary of all of this is the pupil size. So this treatment, like rightly mentioned by Dr. Mohita, is also pupil dependent. So you are creating actually a refractive surface on the cornea. The pupil in photopic light conditions should be 3.5 maximum. And in mesopic or scotopic conditions should be minimum 4.5. If this does not match, the patient is not fit for this treatment. So it's very important that we give a contact lens trial, make sure that the patient is happy, look at the pupil size in different conditions, and then only go ahead and do the treatment if possible. Even the optical zone selection is dependent on the size of the pupil, which we always do. So here the pupil background, we have different ways of measuring. We can use either a Cirrus platform or a Amaris, or I use a wavefront analyzer to get the exact pupil size. And then this treatment, once we get the pupil diameter, either photopic or scotopic, that is taken in. So overall view, this is a summary that there are inclusion criteria. Of course, there are exclusion criteria like any other ocular pathology, and treatment planning. Just a little bit about the treatment planning. This is a very simple chart from Schwinn. If the patient is anisometropia tolerant of more than 1 diopter and is not tolerant at all, then there is no treatment possible for that patient. But if your photopic pupil is 2.5 and 3.5, your scotopic pupil is 4.5, the acceptance is increased to recover in multiple. So I'm going down the chart, and yes, then it's moderate to high. Patient will be happy with Presbymax hybrid or Presbymax monovision. So this is a simple chart that has to be followed. and the patient will be quite happy with the treatment. So most important, patients have to be motivated, and we have to make sure that their side effects, you should have a contact lens trial. Once the contact lens trial should be there at least for a week, we normally give it for a week. And of course, we check the pupil size, the optical zone, and there is a lot of chair time that is included. Here, very important is the treatment, how it goes. Just the Presbymax, this is how it goes. And the optical zone is selected again according to the pupil size. So you can see that presbyopic myopia, the optical zone is smaller, but presbyopic hyperopia, the optical zone gets larger. If there is more astigmatism, the optical zone will get even larger. So you can go till 7 millimeters optical zone. This is just the way the whole chart really looks. You can see that the presby ad in the center is 1.75. Your option of micro monovision, hybrid or monocular, that's on the right hand side. And you can feed in the data that is there. And the near data, of course, you have to treat for near depending on what the patient is actually accepting. The best part of this treatment is that it is reversible. Let us say that we take this, there is a lot of neuroadaptation. I don't know, my patients find sometimes between 1 month to 4 months to adapt to this kind of vision. I don't know what is Mohita's experience, but they do find. But the good part here is that it is reversible. So this is the OD treatment that you can see. And this is the format that you see in the dominant eye and the non-dominant eye. So if the patient is unhappy and we have treated a plus 2.25, we can do a minus 2.25 treatment in the non-dominant eye and reverse the whole asphericity that we have created on the surface of the cornea. So the bi-aspheric surface, that means the center for near and the periphery for reading, can be corrected and the patient can go back to like a normal LASIK treatment. So this is a reversal platform as to how it will actually look on the ablation depth profile. Of course, important to get all your data very, very well. The cycloplegia is subject to acceptance and all the rest of the treatment has to be looked at. So in my experience, hyperopes are very happy between the age of 46 and 50. High astigmatics are happy, but I'm not happy with myopes and low myopes because they tend to compare with the normal vision, myopic vision that they are already having. They're short-sighted. They want that kind of sharp vision in presbyopic, which is not possible. So this is my experience with the Presbyon. And don't forget, friends, at least Schwind is charging us for every treatment. So what I have found that the treatment lasts for about 3 years to 4 years and they need a retreatment. And Schwind will charge you again for a retreatment. And if there is a retreatment in 1 year, they're going to charge you again in 1 year. So this is one thing. And I feel cornea modulates over time. And that's the reason why if you see that steepening that is occurring in the center over 3 years, 4 years, it really doesn't last so long. This is my experience. Of course,